like that. So the next question becomes, when you see that clot, how do you manage it? So even before that, you have to understand that when you see a thrombus in an MI, it actually has bad prognostic, it's a bad prognostic marker. There's a chance, if you put a stent, the stent is going to get thrombosed more. There could be distal embolization, I'll show you a picture of that. There's more myocardial damage. It's an in-hospital adverse outcome and also long-term adverse outcome. So the first step is the pharmacological step before you take your tools out. So you have to make sure, like we said, it's a thrombogenic milieu, so you have to make sure there's no more thrombus propagation, right? So you have to make sure that the patient has been loaded with aspirin, number one. The P2Y2 receptor has also been loaded, which is the prasugrel and more preferably ticagrelor. You have to make sure the patient is heparinized where the SCT is at least 150. And then this GP2B3A, which is falling out of fashion, we hardly ever use this in a routine PCR, even routine STEMI, I hardly use it, except when I see a huge thrombus burden like this. We definitely want to use a GP2B3 in this case. And this is, as you know, it's the GP2B3A is the final pathway in the platelet aggregation. And like again, going back to the thrombogenic milieu, there is the platelets come and releases the platelet aggregating factors, which are antiplatelets, and they tend to clot more and more. So we're inhibiting the final pathway with the GP2B3A. So that's the first thing to understand. It's very important. We cannot miss that. The second one is you can use some vasodilators in certain cases because if there's a thrombus associated in MI, there's sometimes associated vasospasm. So to relieve that vasospasm, you can use nitroglycerin, nitrite, adenosine, or calcium channel blockers. But this is not something that you have to do routinely. When you are suspecting a spasm with the thrombus, you can use this one. And then you take your tools out. So most commonly we use the mechanical approach. We just suck the clot out. I know this is available in Bangladesh. We can use Pronto or Expert device to get the clot out. And like somebody was mentioning that, get the device out. And then you can actually see the clot like that if you want to in some cases. So is there any data in favor of using the device? In 2008, there's a lot of excitement when the TAPUS trial came out. It showed the myocardial blood rate actually improved with the device. But then that study actually was not powered to detect any difference in clinical events. So afterwards, in 2014 and 15, the TOPO1 TASTE trial came out, and they actually showed no difference in the clinical outcomes when you use a mechanical thrombus aspiration in routine cases. Actually, in some cases, it increased the chance of having a stroke. So the guidelines rapidly changed, and this is a meta-analysis where you can see the same thing that I mentioned. And the guidelines rapidly changed, and now it's both for ACC and ESC, it's a class 2 indication, meaning like you should not use a mechanical thrombus aspiration device routinely. You can use it selectively when you see a high thrombus burden. And then very recently in TCT last year, I think November 2021, the CHEETAH trial showed some promise with this Penumbra device, which is similar, but there is a suction device outside, some mechanical aspiration, continuous aspiration. And it's not a very large trial, only 400 patients, but it showed some positive results. We use Penumbra once in a while when I see a very large thrombus burden study. And I'm not going to even talk about Angio yet because the last time I used it when I was in my fellowship. I thought you would ask for mention if he's here when was the last time he used it. And the AMI trial was a negative trial. So some people have tried deferred stenting. There's no strong data, but what they do is they see a large thrombus burden, they put these patients on GP2B3A on 48, 24 hours, and then they bring them back for the stent. And their argument is, if you put a stent right away, you may not be able to select the right size of the stent, so there is a chance of undersizing and malapposition. So if you give time, there is less chance of thrombosis. When you bring them back, you can size the stent correctly. But that's not my practice because I'm increasing the length of the stay for the hospital for the patient, which is not a good thing. Increases his cost, and I really want to send him home. And the other important thing is that while I'm waiting on that, the vessel can be approved, which I would dread. Some people have used intercoronary thrombolytics, and there's some limited registry data. and they use intracoronary thrombolytic CT and 10 articulates, and that includes the TIMI flow plate. Some people use the other catheter, smaller catheter, to go up inside the vessel and deliver the thrombolytic therapy. So what do you do after, when you're sending this patient home? You definitely want to continue the aspirin indefinitely. And this is the case where normally, like Azam said in the previous case, you do a dual antiplatelet therapy for a year. That's the standard practice. But in this case, you can continue that beyond a year, and we have some data that shows a benefit, especially in people who have less bleeding risk. So I usually make a shared decision. I sit down with my patient, if this young patient, and if he had an MI 1 year ago with large thrombus volume, and if he agrees that he would want to continue the Plavix, I would do that. So going back, to our patient, the patient did good. In some cases, you still can see some residual thrombus, and in a lot of cases, you can see a distal embolization. If it's a small vessel, I usually do not chase after that. If it's a large one, I still will try to use my mechanical NCS for whatever I can do with that. But this is my partner's case, but this is my case, which is always pristine. I'm joking. So the result was very good, and the patient can go home. So I guess, again, for the younger physicians, the take-home message is, it is not uncommon that you're going to see a large thrombus burden, especially in a STEMI situation. So don't get panicked. It's a normal thing. Your job is to, suck the blood out and use a GP2B3A inhibitor. And be cognizant that it is associated with adverse outcomes. So if you have to be very cautious with the size of the stent, especially if you're undersizing the stent, there's an increased chance of getting that the stent re-uploaded with the thrombus, so the patient may come back within 24 to 48 hours. You have to be extremely careful. And you can consider long-term TAVT for these patients. And as we always say, medicine is not a science, it's also an art, so use your judgment. Thank you.
Thank you for nice presentation, brilliant presentation. Nasser Khan, you have mentioned at every corner of management of fused thrombus model. Especially, there is also indication of fused thrombus, angiographic indication of thrombus fused model. And already you have, if we could find the distal landing zone, how do we manage the patient setting? Is a wrong question. Another question, have any role of direct stenting? Because rarely we use balloon in case of primary STA line. And any role of power stenting?
I would like to opinion as well, but I always try to wire it as much as I can. And I've been put in many cases finding I always have to balloon it first to see, because I really want to know what the size of the vessel is. My concern to a primary stenting would be, I don't want to undersize my stent. I really want to see the vessel before I put a stent in. So I would like the thing that I've been fooled with is that though I start proximally and probably the lesion is further down. So I try to balloon further distance to find the exact spot where the stenosis is. Because because of the thrombus, the vessel may be occluded proximally, but the true lesion may be further down. So I try to go, if I'm not seeing a flow, usually I see a good flow with the first one or two balloons. If I'm not seeing the flow, then I go down with the balloon to find the true stenosis. When I hit that spot, I can see the whole vessel. And that really helps me to size the stent, and then I put a stent. I'd like to know what...
From my experience, I can say most of the cases, direct stenting is used by primary PCI because direct stenting cause less no flow or slow flow phenomena. And if I don't see the landing zone, of course, then I have to dilate the vessel first. Otherwise, most of the cases, in my experience, is around 70 to 80% cases, direct stenting is feasible. And if it is needed, then you can full dilate the vessel to optimize the stent condition.
I have a question. I ask you a comment regarding the use of intracoronary imaging during primary PCI. In which cases do you have to do intracoronary imaging during primary PCI?
I guess before that, can you answer what would be your practice, primary stenting or balloon in a stenting case?
Actually, there is no algorithm for a huge numbers. So the last message I like, gentlemen, and you
the creative art of medicine. So sometimes, I mean, when you have large vessels like this, huge thrombus, even aspiration is not effective. So you are pushing something down. I think in these cases, huge thrombus, you don't have any good solution. The only solution, rational solution, is to give intracoronary thrombolytic low doses, wait day after, and continue to see thrombolysis or inhibitors. There is sometimes it works. So I think this way, and see, if you have this immunization after stenting, sometimes also mechanical solution that we just push or try to fragment this immunization with a balloon. Just push the balloon and you will get back your restored flow. So it depends. It's art of medicine.
Thank you. As far as the question regarding imaging, we do not routinely use imaging in a STEMI situation unless I'm trying to size the stent, I can get my IVUS out. But if I see a thrombus, I showed you an OCT picture, but I would not routinely do an OCT, and I'd like to know what would be your opinion on that. So, imaging in a thrombus situation. Exactly. That's exactly right. So,
It is enough to go with microcatheter, inject small blood, quantitative of contrast, and you will see that you have this. I think IVUS is not useful in this
So I think we both agree, we all agree that we routinely do not use an imaging in a thrombus burden because we already know there's a thrombus burden in a stent situation. Yes, Asha, you have a question, please?
That's great talk. Could we address the issue of de-escalation of debt? Ordinarily, of course, post-STEMI with this degree of thrombus burden, that would mandate potent V2Y12 blockers in terms of debt. So either ticagrelor or prasugrel. But at what point would you de-escalate, and would your decision regarding the timing of de-escalation change, given that this was a STEMI case with high thrombus burden versus, say, an ordinary regular STEMI?
That's a great question, actually. And the true answer is that there is no really hard data. And again, the art of medicine. If I have a young patient who had an MI at age 45 with huge thrombus burden, I probably would leave him on DAPT indefinitely unless he's having a bleeding problem. There is one exception though. If that patient, say, has atrial fibrillation or for any other reason, the patient is on anticoagulation, all the new data shows that, drop the aspirin. So we would do double therapy but not triple therapy. So in that case, the patient is already, say, on a DOAC or any other anticoagulation, I would just add clopidogrel but not aspirin.
But say he's only on that, at what point would you continue him on the potent V2Y12 and for how long? Or would you stop it and switch him to clopidogrel?
Correct. So ticagrelor has, as you know, has more benefit, has proven to be more benefit than clopidogrel. So that would be my choice for any STEMIs or non-STEMIs. However, what I have done beyond a year, because it's more expensive. So in USA, we always have to think about, we think, in USA you can prescribe mercury pump. That's not the case though. We still have to think about the cost of the medicine, which is, so ticagrelor is very expensive, but clopidogrel is generic enough, it's cheaper. So what I do in my practice is once a year is over, if I want to keep them on DAPT, I switch the ticagrelor to clopidogrel. And that's easier for the patient also because he has to take it on the medicine. But that goes a big question.
That is finished. Another question is, the practice is here that in such patients, somebody discharges the patient with some oral anticoagulants for some weeks, 1 or 2 weeks. Then they advise patient to come back and they endure again. And it's usually seen that the lesions are clear, free of thrombus. While the original lesion is seen there, and it's easier to fix the lesion. So what is your take on that practice?
Again, we don't have any data that you can prescribe anticoagulants for these cases. I would like to know from the panel as well. So they're saying, in some cases, they would prescribe anticoagulation for a few weeks in these cases. But like I said, in my practice in USA, we usually do not do anticoagulation. We just do DAPT, but I'd like to know what the panel would say.
I think it takes, in a STEMI patient, it takes much time in order to recover or to save myocardium. I think it's much better to go with small doses with thrombolysis, intracoronary thrombolysis, wait just 12 hours and go back to the patient. You have more chance to open, at least to restore flow.
Thank you so much, brother.